I am Jeff Moulter, certified registered nurse anesthetist with Western Reserve Anesthesia Education, and today I'm going to talk to you about the fascia iliaca compartment block. This is an anterior approach to the lumbar plexus that can result in extensive anesthesia and analgesia of the hip, anterior lateral thigh, and the anterior knee. It was first described in 1989 by Dalens and colleagues. Indications include hip fractures, hip arthroplasties, and hip arthroscopies, also skin grafting. This block reliably blocks the femoral nerve and the lateral femoral cutaneous nerves. Blocks of adjacent nerves are also possible, including the ilioinguinal nerve, the genitofemoral nerve, the obturator nerve, and the accessory obturator nerves. The old style of performing this block was by tactile sensation or by feeling two pops, but now with the advent of ultrasound, this block is relatively simple to perform. Now, each year, the CDC reports over 300,000 people greater than age 65 years old are hospitalized for hip fractures. We know that women experience three-fourths of all hip fractures, and the odds of hip fractures increase with increasing age. These are great candidates for fasciailiac compartment blocks. As we all know, many times these elderly patients come in, they're from long-term care facilities. Some of them have underlying dementia or Alzheimer's disease, and if they don't, they come in and we load them up with opioids and we make them more confused than when they walked in the door, and we make them more likely to fall down or injure themselves. So the fascia iliaca compartment block is a great alternative to loading up these patients with opioids. Now here is the nerve innervation to the proximal femur. On the left side we have the anterior view, on the right side we have the posterior view. We could see the polka dotted area of the femur that is innervated by the femoral nerve. The brick pattern on the medial side would be the obturator nerve, and you could see um, a small portion, and also on the posterior aspect would be innervated by the sacral plexus. Just a review of the pelvic anatomy here. We could see the femoral nerve coming down through the pelvis underneath the inguinal ligament. We also see the lateral femoral cutaneous nerve also passing down below the inguinal ligament. Now we want to note that the block of the anterior branch of the obturator is unreliable with this block. This block does capture the femoral nerve and the lateral femoral cutaneous nerves pretty reliably. However, we will get a cephalad spread, and we can capture most of these other nerves as well by using a large volume. So we inject our local anesthetic. We're going to see the local anesthetic spread this way back towards the lumbar plexus. Now the iliacus and the psoas muscles become the iliopsoas muscle below the level of the inguinal ligament. The fascia iliaca is located anterior to the iliacus muscle, or it's on its surface within the pelvis. It is bound superior laterally by the iliac crest and medially merges with the fascia overlying the psoas muscle. Both the femoral nerve and the lateral femoral cutaneous nerve of the thigh lie under the fascia iliacus in their intrapelvic course. And again, when we perform this injection, we're going to see that local anesthetic spread back towards the lumbar plexus. Here we can see the sensory block created by the fascia iliaca compartment block. It's important to note that motor block can occur and has been reported. So we want to be very careful in these patients. We want to use a dilute local anesthetic when we're doing this block, but it is possible to get some quad weakness because we're getting the femoral nerve when we do this block. Here is the anterior view of the inguinal crease. We want to note the positions of the femoral artery, the femoral nerve, the anterior superior iliac spine, the sartorius, and the iliopsoas muscles. Our goal is to place our needle under the fascia iliaca and actually peel the iliopsoas or iliacus muscle off of the fascia. We actually hydrodissect with a large volume of local anesthetic. And here we could see from medial to lateral the femoral vein, the femoral artery, the femoral nerve. We see the lateral femoral cutaneous nerve on the left side of the screen. We see the fascia lata, the fascia iliaca, and we see the iliopsoas muscle. This clip is going to demonstrate how our local anesthetic is going to infiltrate and surround the femoral and lateral femoral cutaneous nerves. And we want to remember that this video is showing the local anesthetic spreading medially and laterally, but we also want to remember that this local anesthetic is also going to spread cephalad and caudad as well. Now here you can see our probe is placed on the lower right hand part of the screen. It's placed in a sagittal plane just over the iliacus muscle, just medial to the anterior superior iliac spine over the inguinal ligament. Sometimes the probe could be oriented towards the patient's umbilicus, but when we're looking at this slide, the right side is caudad, the left side is cephalad, and we're going to get this bow tie-like appearance on the screen. And we're going to label that anatomy, and this is what that anatomy looks like. We have the fascia lata, the fascia iliaca, we have the interoblique muscle on the left side, we have the sartorius muscle on the right side, we have our large iliacus muscle, and we have our ilium on the lower left part of the screen, which is shown up as hyperechoic bone. And again, here's the sonoanatomy, and here's what those labels look like. So our goal is to bring that needle from the caudad position just over the sartorius. So you'll see it come from the right side of the screen. We're going to pop underneath the fascia iliaca, and we're going to actually peel the muscle off of the fascia iliaca. So we're going to inject that local anesthetic and see it spread kind of like a lens or a football. The equipment needed will be a skin marker, ChloraPrep, sterile gloves, gel, and a probe cover. We'll be using a 21 gauge 80 to 100 millimeter short bevel echogenic needle. Our local anesthetic, we're going to use a very dilute local, 0.2% ropivacaine. We're going to use 30 to 60 milliliters of volume, and we're going to add 10 milligrams of Decadron to this local to extend the block. We'll be using a mid-frequency linear probe. Now we're doing this block. The patient will be in the supine position with extension of the hip. In some larger patients, you may need to have a nurse retract the pannus, or you may have to put the patient in some reverse Trendelenburg in order to assist you. We'll start with the transducer in the transverse position. As you can see on the left side of the screen, we'll locate the femoral vessels and the femoral nerve, and then we're going to slide laterally and identify the iliacus muscle or the iliopsoas muscle. Remember that the iliacus muscle forms a ridge because of the underlying bone of the superior pubic ramus. Once the iliacus muscle is identified, we're going to rotate the transducer to a sagittal position, which is what you see in the middle of the screen. Sometimes by tilting the transducer laterally enhances imaging of the fascia iliaca. Here is as demonstrated by Hubbard. Note how the needle enters below the inguinal ligament, but it is advanced until its final resting place is actually above the inguinal ligament. So this is actually a suprainguinal approach. Now we will be in plane with our needle. Our needle will be coming from caudad to cephalad. It's critical that the needle tip be positioned between the fascia iliaca and the iliacus muscle. The needle travels under the inguinal ligament, and as always, when we're doing these blocks, you want to make sure that you're ambidextrous, because when you're on the patient's right side, you're going to have the transducer in your left hand and the needle in your right hand, and you're going to have the opposite. When you're on the patient's left side, you're going to have the transducer in your right hand and the needle in your left hand. In this clip, you can see that we are scanning from medial to laterally. So on the right side is medial, the left side is lateral, and we are actually identifying the femoral vein and femoral artery. You can see the femoral nerve there. We're going to slide laterally. We see the very large iliopsoas muscle. You can see the ilium bone rotating back. And now at this point, once I identify the muscle, I'm turning my probe into a sagittal position. So now the right side is caudad. You can see the sartorius muscle there on the right, sliding up towards the cephalad position. We'll see the internal oblique muscle there on the left. And then I'm going to come back to the middle of the screen. And again, you can see that fascia overlying the iliopsoas muscle there. So that would be a medial to lateral scan. There's our bow tie that we're looking for. You also could perform a lateral to medial scan. So you could start over the anterior superior iliac spine, and you could slide medially, and there you could see the iliopsoas muscle. I'm going to rotate that probe again. So the left side is cephalad and the right side is caudad. And once again, we could see the sartorius muscle on the right side of the screen and the internal oblique on the left side of the screen. We see the iliacus muscle. We could see the fascial layer on top of it. This is the actual injection itself here. We're going to identify the anatomy. You're going to see the needle coming from the right side of the screen, which is the caudad position. You're going to note that the first initial injection is just outside the fascia iliaca. See that first injection, and then we're going to advance that needle just a little bit more to get underneath the fascia, right there, and you can see how the muscle is peeling off of the fascia. Fantastic spread. And as that local anesthetic is spreading more cephalad, we're going to advance that needle a little bit more just to get more of a cephalad spread. Major complications of all peripheral nerve blocks. This was a retrospective study in 2002, 50,000 peripheral nerve blocks. We could see that the major complications are pretty rare. Risks and side effects include falls, infection, vascular puncture, intravascular injection, and failed block. Again, that is the fascia iliaca compartment block. My name is Jeff Moulter, certified registered nurse anesthetist with Western Reserve Anesthesia Education. If you have any questions, please go to our website, www.wrae.net, or you can email me. My email is my name, Jeff Moulter, @me.com. Thank you.